Without further ado, I do want to introduce our next speaker, Dr. Stephen Edmundowicz, who is a professor of medicine and the chair of our division, the chief of our division at the University of Colorado, who will be talking about the other end of the spectrum, perhaps some areas in which we can de-escalate the screening and surveillance that we're offering. So Dr. Edmundowicz, thank you so much for joining us today.
Thank you so much, Swati. That was a great lecture. I'm still trying to get my slides into presentation mode. There we go. Excellent. Well, it's really a pleasure to be part of this program, and I want to echo Sachin's comments from the last session that the course directors and particularly Christy Click have done an outstanding job of getting us all together here. And I want to thank all of you who are still with us at this hour in the afternoon, going forward with the last presentation and an interesting discussion. These are my disclosures for the lecture. I joined this division in 2015, and I have to say one of the things that I'm extremely proud of is the heritage of this division, particularly in the area of colon cancer screening. I don't have to tell many of you in the audience what great mentors, physicians, and leaders Joel Levine and Dennis Anand were for the decades that they served the Colorado and the Denver population. Many of you know that Joel was responsible for much of the work with the American College of Physicians to approve colon cancer screening, and Dennis is just an unbelievably educated teacher for many, many decades. Unfortunately, we lost both of these fine individuals in October in 2020. August and October of 2020. I took time for us to pause as a division to see what we were going to do to replace this unbelievable mentorship and leadership that we've had. And I'm happy to report that with what you just experienced with Swati Patel servicing the VA and the University Hospital, as well as with the new addition of Jordan Karlitz at Denver Health, colon cancer screening will remain not only on our radar screen, but remain a focus of this division for years to come. So I was given the task to talk about when are we doing too much? And I think as gastroenterologists, we do need to pause sometimes and look at our practices and what are we doing. And I want to say that as Swati just so nicely identified, I'm not sure that we can say that we're doing too much in the area of screening. We clearly have work to do in getting the patients that are eligible for screening screened. We need to continue to try to break down these barriers. And it's very clear to me from the arguments that have been made that we need to expand our screening to include the 45 to 50-year-old population that are at normal risk for colon cancer. How should we do this? It's not clear if we should be incorporating a staged screening process for these individuals. Certainly things like FIT and other alternative tests may save money by excluding individuals from having to go on to colonoscopy, but there's going to be a false negative rate. And one of the great wins I think we've seen in colon cancer screening and colon cancer prevention is the ability to prevent colon cancer with colonoscopy by removing adenomas. So I believe this will be debated clearly over the next decade. I'm hoping that we'll know before then how we should proceed with this population. But I suspect that colonoscopy will be advocated as the best and primary screening test that we should offer our patients, all patients. And if the patients are not willing to undergo colonoscopy, unless there are some other draconian cost-saving or financial measures approach to us, I think we would continue with that as the primary approach. And we would use two-stage screening for patients who refuse colonoscopy or simply can't have colonoscopy. Clearly, we need to expand to age 45. I think that argument is clear. And more importantly, I think we need to push to really engage those individuals who are not getting screened now who are eligible for screening. It is very disheartening for all of us to diagnose a colon cancer in our endoscopy labs. And we hope that by further education, further breaking out into the populations that are not getting high incidences of screening now, that we'll be able to make an impact on this disease. we are still diagnosing over 50,000 colon cancer cases a year in this country. And those are all, in my mind, preventable conditions. So how do we bend this attitude? What do we do for the patients that just are unwilling to get done? There's a number of programs that have been started. We're looking at trying to engage even further with the community environment to try to get into these areas and try to show patients this is really not anything more than our attempts to try to prevent them from developing a disease that can significantly impact their life and their family's lives. Now, when we're talking about doing too much, one of the areas that we can discuss, I think, with really good data is surveillance. Evolving data suggests that we are overutilizing surveillance. This data allowed modifications of the 2012 surveillance guidelines. And as you know, the Multi-Society Task Force released new guidelines in early 2020 that incorporated this evidence that has been available since the early 2010s to 2020s. This has been published in the recommendations for follow-up after colonoscopy that are listed here on this slide. If you don't have a copy of this, you should certainly get it. You should particularly take a couple of the tables that I'm going to show you in just a few minutes and post them in your endoscopy facilities, because this really is the guidance that we're getting from the experts in this space, and we feel very comfortable following that guidance based on this data. I'm going to show you some of the data very quickly, and I'm sure many of you are familiar with it, but probably the first paper was this New England Journal publication in 2013. It looked at more than 300,000 individuals who had a normal colonoscopy and colon cancer screening and saw that they had an amazingly reduced risk for the incidence of colorectal cancer, and it was durable for at least 15 years. So this was one of the first papers that demonstrated the benefits of colonoscopy and how protective it was if you had a normal colonoscopy. Another study from the United States, a similar look at this population, only 100,000 patients, but they also showed that there was a greatly reduced risk of incident colorectal cancer and certainly fatal colorectal cancer in patients that had been screened. So this evidence really supports the fact that a normal colonoscopy does protect you for a period of time. And that time certainly is 10 years and perhaps longer. The other aspect that was brought out in looking at screening and surveillance was the high risk versus low risk adenomas. And this has evolved over the past decade to the point where we now feel very comfortable that patients with low risk adenomas, and I'll describe those in detail, but typically those that are not greater than a centimeter, don't have high risk dysplasia, and are not tubulovillous. Patients with low-risk adenomas have a very low risk of fatal colorectal cancer, in fact, lower than the normal population of unscreened patients. So there clearly seems to be a logic for strategizing or for tiering our surveillance so that patients with low-risk adenomas are not considered in need of high-risk surveillance. This was also borne out in the US prostate cancer screening trial that involved sigmoidoscopy screening in those patients that presented for that trial. And they found also that the incidence of fatal colorectal cancer was increased in patients with high-risk adenomas, but not in those with low-risk adenomas. The United Kingdom tried to characterize this even further, looking at intermediate risk patients. And they also found that these showed that they had a better outcome. These intermediate risk, or what we would consider high risk patients, would have a better outcome with surveillance than with not surveilling them. And then finally, there's a group of studies from the United States looking at the issue with surveillance and follow-up, and a large portion of it really comes down to the quality of colonoscopy that's being done. There's evidence that perhaps up to 50% of colorectal cancers that develop in patients that are screened are from missed lesions. There's clear evidence that endoscopists with low adenoma detection rates have higher rates of interval cancers. We know that with improving the adenoma detection rates, the interval cancer rate declines. And there's now interesting data on incomplete resection of polyps that highlights the importance of careful technique in polyp removal. All of these are operator-dependent issues that we can control and improve. So what's expected of us in this whole gamut of colon cancer screening and surveillance? What's expected of us in our practices? One is we need to have excellent preps to detect all polyps greater than 5 millimeters. If you're not getting excellent preps to do that, then you're really not performing high quality colonoscopy and you're not protecting your patients. If you have a poor prep, the procedure needs to be repeated. And then there's some operator issues that we as individuals should take on and be sure that we are meeting these guidelines. First is we should clearly be having a 95% cecal intubation rate. If you're not seeing the whole colon, then you're not protecting your patients. And that needs to be improved upon. The adenoma detection rate, the minimal adenoma detection rate should be 30% in males and 20% in females. This is a technique-driven detection. It can be done with education. You can improve your adenoma detection rate. It's been shown that you can use devices to improve your adenoma detection rate. And we're hoping that there will be increased interest in some of the AI technology and software that will help all of us become better detectors. And finally, we need to work on our polyp resection rate and make sure that when we do identify adenomas, that we're resecting them completely. We're not leaving residual tissue. The other issue that's changed going forward is that we really have categorized adenomas into two specific categories: the high-risk patient or the high-risk adenoma and the low risk. And as I said, the high-risk adenoma is any advanced adenoma that has high-grade dysplasia, tubular villus pathology, or one that is greater than 10 millimeters in size. That really puts the patients in a different category for further surveillance, whereas the low-risk adenomas that are not more than 10 millimeters in size and don't have these characteristics are really closer to having a negative colonoscopy. And this, I think, is where we're going to see some savings in the amount of colonoscopy that we need to do in the future. So if you look at the definitions that I've already gone over from the multi-society recommendations, the low-risk adenoma is listed as 1 to 2 adenomas that are less than 10 millimeters in size. The high-risk adenoma is those that have the features of an advanced adenoma greater than 10, tubular villus histology, high-grade dysplasia. And then the adequate ADR that they're expecting of all investigators that are doing these procedures or all screeners that are doing these procedures is adenoma detection rates greater than 30% in men, greater than 20% in women. You must have an adequate bowel prep, and you must be doing a complete examination. And when you follow those criteria, you're essentially performing a high quality examination, which is what we want to see from all practitioners. Now, why is this so important? Well, if you look at this in a graphical demonstration, and this is a summary of many of the 8 surveillance studies that have been done over the past decade, you can see that patients that had 1 to 2 adenomas, the low-risk adenomas that were less than 10 millimeters, are really very similar in their incidence of metachronous polyps in follow-up as the patients that had no adenomas. It's essentially the same as a normal colonoscopy. Whereas those that had a high-risk adenoma had a much higher incidence of metachronous polyps and obviously need to undergo surveillance of some type. The old recommendations that we followed in 2012 set a recommended surveillance interval of 5 to 10 years for patients that had low-risk adenomas. That's now changed. It also kept the high-risk adenomas as a 3-year interval. That's also changing for some of the patients. And I want to go over this with you because this is the graph that I want you to post in your endoscopy facility, the chart that you can get from the reference that I had in my first slide. And this is the 2020 recommendations from the Multi-Society Task Force. And that is that if you have a normal colonoscopy, you do not need an examination for at least 10 years. If you have 1 or 2 tubular adenomas less than 10 millimeters that don't have any of the high-risk features, you have a reasonable incidence of surveillance colonoscopy done at 7 to 10 years. So a very prolonged interval. If you have 3 to 4 tubular adenomas that don't have the high-risk features, that can be done in 3 to 5 years. And then if you have the larger adenomas greater than 10 millimeters or the abnormal histology or the high-grade dysplasia, those patients should be followed up in 3 years. You'll notice the only patients that should have an interval under 3 years are those that have more than 10 adenomas on the examination. And even that is unclear how strong that recommendation will be. And currently the recommendation for a piecemeal resection of an adenoma greater than 20 millimeters is a 6-month follow-up exam. And then after that exam, the interval will be based on the data of what you find. And I'll show that slide to you in just a minute. So this is really key that we understand these intervals. And as I've explained to you in the first couple of slides, the data supporting this to actually push these intervals back further is very strong. And I think it should be widely accepted. So if you clump this all together, you're performing your high risk or your high quality colonoscopy in average risk patients. You have a risk stratified colonoscopy interval, depending on what you've detected, from 10 years for normal, and 7 to 10 years for 1 to 2 adenomas, 5 to 10 years for small sessile serrated polyps, 3 to 5 years for patients that have these multiple adenomas, and then 3 years for the patients that have the high risk adenomas. And then finally, the 1-year interval for those that have more than 10 adenomas. Now, this was a battle as this multi-society task force document went through the societies, because there really was stronger evidence to push the intervals longer. But there was pushback from the societies because they felt that there was a dramatic change in practice, and that patients may not be given the benefit of having high quality colonoscopy in all practices. So the compromise was to have these ranges of 7 to 10 years and 5 to 10 years. But I honestly think that as we go forward, we're going to see that these are going to be grouped together because the data do support this, and that we'll likely see a 10-year interval for these 3 categories, a 5-year interval for this category, and then a 3-year interval for this category. And there won't be the variation that's currently in the current documents. I'm not sure when the new guidelines will be released regarding this. I suspect, since it's typically taken 5 to 8 years to accept this and have data to support it, that it will be a little longer. But you should feel very comfortable going to the longer age range on these categories because the data supports that. So why do we overuse colonoscopy? Well, the biggest reason is that most physicians, many physicians, not most, but many physicians are not following the recommended intervals. They're still practicing in the way they practiced when they first trained. They're repeating colonoscopies at 3-year intervals regardless of the risk. And the patients are getting essentially extra endoscopy exams that they don't need. There's an alternative to that, and that is there is pressure from patients who are very concerned about the fact that they've had polyps and they want to be examined again. And as physicians, I think it's our obligation to really redirect these patient inquiries to show them where the guidelines and the evidence are, and that they're safe at waiting these intervals. Other issues are just technical issues regarding the data. Trying to correlate the pathology results from previous colonoscopies can be challenging sometimes. So often we don't work too hard at getting it, and we say, well, let's just repeat the exam. We also don't often get reinforced preparation for the initial examination in terms of the quality of the prep, and that can sometimes lead to extra exams that we could avoid. And finally, a lot of physicians feel uncomfortable relying on a previous endoscopist examination. I think if we're all practicing high quality colonoscopy, and we should really strive for that to be our goal, that shouldn't be an issue, because you know that the physician that did the last exam has a high adenoma detection rate and can get to the cecum all the time. The other issue with surveillance is that what happens after you do the second examination. In other words, you found 1 to 2 adenomas, you did your recommended interval surveillance, you find a normal colonoscopy. Are you comfortable pushing that patient back to the 10-year interval or not? Well, you should be. And the data supports that, as it does for the findings that I've listed here, or that are listed here in this table for the other positive findings that could occur at that colonoscopy. For the intermediate class, you should feel very comfortable following these guidelines as well. And for the patients that have high-risk adenomas, we are pushing the interval to 5 years, because there's good evidence that if you have a normal colonoscopy after that, or a colonoscopy with only 1 or 2 low-risk adenomas, you can get away with a larger interval between examinations, and you should feel comfortable following these recommendations. Now, why, again, are we not following these intervals? Well, most of the time, I think it's because the physicians aren't aware of the intervals. Some of it is pressure from patients. And a portion of it is just not correlating the pathology results with your colonoscopy findings. And we really need to do a better job at all of that. I'd like to switch gears for a second then, and for the rest of my talk, discuss what do we do about the individuals who have made it to those wonderful years. When do we stop screening and surveillance? And I think reviewing the literature in the space is pretty clear that this needs to be an individualized decision between the physician and the patient. The compelling information is that the risk for colon cancer per 100,000 population is really highest in the older ages. So it's difficult to just dismiss this population. If you look at this graphic from a nice article that I'm quoting here in the Mayo Clinic Proceedings, you'll see that the incidence in the 70 to 74 population, even going above that, continues to increase year by year. So we can't just ignore this population and say they're not at risk for colon cancer. At the same point in time, the benefit for colon cancer screening really is in those individuals that have 10 years of life expectancy ahead of them. Because by the time you identify a polyp and prevent a cancer from forming, you have given them a window of opportunity that is going to be no different if their mortality is within 10 years. So when do we stop screening and surveillance? The lag time from the benefit of screening for colorectal cancer is approximately 10 years. So in patients with a life expectancy less than 10 years, they're unlikely to benefit from screening. And the benefit of surveillance endoscopy in this elderly population is really difficult to assess. I think this data is much stronger for screening itself, and we should push those individuals who got to this age and have not been screened to have some screening done if their life expectancy is more than 10 years. I believe this algorithm very nicely puts this into perspective. If your patients are over 75 and they're presenting for initial colorectal cancer screening, you can use standardized systems, whether they're congestive heart failure, cardiac, cancer survival statistics, to understand, does this patient have a 10-year survival predicted or not? If they're not in that category, then you really shouldn't do colorectal cancer screening. On the other hand, if they are an excellent candidate, if they do have a score that would suggest they're going to live for more than 10 years, and agreeable, this has to be individualized because it can't be absolute. But if your suspicion is that they have a 10-year survival, then I think you should discuss available screening options with them and work on the patient preference of what the screening test should be and what they're willing to undergo. If the patient prefers invasive testing, then by all means proceed with a colonoscopy. If they prefer non-invasive testing, then whichever non-invasive test you feel is best for this patient, please employ it. If it's negative, repeat for the recommendations of that test. If it's positive, the patient should be considered for a colonoscopy. The age at which we should end surveillance endoscopy, colonoscopy in this group is much less well established. And I think that really has to be individualized based on your patient and their life expectancy. If you look at the recommendations from the different societies that are listed here in the left column, pretty much the common signal is that you should individualize care between 75 and 85, and there really should be against screening anyone over the age of 85, just because the 10-year benefit is unlikely to benefit that patient. And this is what I've summarized here. Individuals 76 to 85, the decision for the first screening or even surveillance should be individualized and based on a number of factors, and screening is really not recommended after the age of 85. The take-home points from my lecture are listed here. Adenomas less than 1 centimeter in size without high-risk features, they should be able to undergo surveillance colonoscopy in 7 to 10 years. For individuals ages 76 to 85, the decision should be individualized, and we should not be screening individuals over the age of 85. I'd like to thank you for your attention and thank you for joining us today for this conference. It's really been a pleasure to be here. And I want to take one last second to remind you that we do have, for those of you that are interested in the whole issue of implementation of population-based colon cancer screening, Jason Dominitz is a great friend of ours, and he is coming to visit us on October 8th. This will be a virtual presentation, and I hope as many of you as possible can join. Thank you again.
Thank you, Steve, for that outstanding overview and presentation, and reminder for all of our attendees to save the date for Jason's visit coming in October